Good evening and welcome to seniors, colleagues. We have planned a short meeting on dengue in pregnancy, and speaker is our own Dr. Dolly Mehra, senior obstetrician from Mehra Nursing Home, past president ROGS. I welcome you, Dolly. अब खाली अपने members को तो introduction देने की जरूरत नहीं है.
बिल्कुल. Thank you so much. I'll directly share my screen and start the proceedings. है ना?
हाँ.
Okay. I hope my screen is visible.
हाँ, visible.
इसको enlarge करना है. This one. Okay. Fine now, na? Everything can be seen.
हाँ.
Okay.
हाँ, दिखता.
So, dengue in pregnancy, it's very important because now every day we are seeing patients day in and out. Dengue is the most widely spreading mosquito-borne viral disease. 2.5 billion people, that is 2/5 of the world's population in tropical and subtropical countries, are at risk. WHO estimates 50 to 100 million dengue infections occurring annually. In India, the risk of dengue has increased in recent years due to rapid urbanization, lifestyle changes, deficient water management, and improper water storage practices. The epidemiological determinants are the agent. Dengue virus belongs to the genus Flavivirus. It is a small single-stranded RNA virus. It has 4 serotypes: dengue, DEN 1, 2, 3, and 4. Infection with a serotype confers lifelong immunity to the virus serotype. Secondary infection with DEN 2 or multiple infections with different serotypes leads to severe form of dengue hemorrhagic and dengue shock syndrome. The vector is the Aedes aegypti or the Aedes albopictus. That are two most important vectors of dengue. They are both high. They both are high vectorially competent, and that is they have a high susceptibility to infecting virus and ability to replicate, ability to transmit virus to another host. Aedes mosquito is domesticated anthropophilic nervous feeder, that is to complete the blood meal. It takes more than one host, and it is discordant. That is, it needs more than one feed to complete one gonadotrophic cycle. Hence, multiple cases in cities are seen. Environmental factors. Aedes mosquito survives best at temperature ranging from 16 to 30 degrees centigrade and a humidity of 60 to 80%, which we see normally nowadays. Female Aedes deposits egg on moist surface from which adults emerge during optimal conditions. Eggs can withstand desiccation and remain viable for more than 1 year. This prolongs the survival in a major issue in prevention and control of dengue. Host risk factors is travel to a dengue endemic area. High-risk patients are infants and elderly, obesity, pregnancy, peptic ulcer disease, women with AUB, hemolytic disease, G6PD deficiency, thalassemia, CHD, diabetes mellitus, hypertension, asthma, chronic renal failure, liver cirrhosis, and patients on steroid and NSAIDs treatment. Clinical course. Dengue has a widespread clinical presentation. Most patients recover following a self-limiting, non-severe clinical course. A few progress to severe disease. The clinical course has 3 phases. Febrile phase, which is following an incubation period of 2 to 7 days. Illness begins with a sudden onset of fever, which is triphasic, headache, flushing, retroorbital pain, muscle and joint pain, anorexia, vomiting, epigastric discomfort, abdominal pain, maculopapular rashes are commonly seen on the neck. The critical phase, or also known as the leakage phase, it is characterized by plasma leakage and hemoconcentration, decreased platelet count 3 to 4 days after fever, abdominal pain, persistent vomiting, mucosal bleeding, lethargy, restlessness, liver enlargement, pleural effusion, ascites, shock when critical volume of plasma is lost through leakage. With prolonged shock, there is organ impairment, metabolic acidosis, DIC, which leads to severe hemorrhage, causing hematocrit to decrease. The third is the recovery phase. The lost fluid due to capillary leakage return back to the circulatory system 24 to 48 hours after the critical phase. The well-being improves, appetite returns, GI symptoms abate, hemodynamic status improves, diuresis ensures. Likelihood of developing pulmonary edema due to fluid overload of the fluid replacement if it is not monitored and regulated. So we have the febrile, again a diagrammatic representation. There is a febrile phase, there is a critical phase, and there is a recovery phase. As I've already mentioned, there is sudden onset of fever in the febrile phase. There is headache, mouth and nose bleeding can be there. There are joint pains, vomiting, rash, and diarrhea. In the critical phase, there is hypotension, pleural effusion, ascites, GI bleeding. In the recovery phase, there can be altered consciousness, seizures, itching, slowing of heart rate, and pulmonary edema can also be seen. This is a diagrammatic representation, a graphical representation rather, of the days of the illness along with the various parameters, that is temperature, potential clinical issues, laboratory changes, the serology and the virology, and the phases of illness. So we see that the antibodies to dengue will be seen only in the third phase. And we have to treat the patient basically in the second phase, that is the critical phase. So in the febrile phase, again, there is fever, headache, arthralgia, myalgia. The tourniquet test will be positive. In the critical phase, the fever subsides, but the warning signs appear, and we have to be very careful about these warning signs. In the recovery phase, the patient will be afebrile. Potential complications in the febrile phase, they can be dehydration. In the critical phase, they can be shock, bleeding, and multi-organ involvement. Whereas in the recovery phase, they'll be opposite, there'll be fluid overload. In the febrile phase, the most common thing which we see is a low WBC count, which is commonly seen. In the critical phase, the platelet will be low and the HCT will rise. In the recovery phase, the WBC rise, platelet rise, and the HCG becomes normal. So, according to the symptoms, the dengue fever can again be classified into two groups: the undifferentiated dengue fever and the severe dengue fever. Undifferentiated dengue fever is like any other viral fever. There is fever, rash, may or may not be present, signs of bleeding or capillary leakage, they may be absent. In the severe dengue fever or dengue hemorrhagic fever, which is further classified according to the severity into four stages. Stage 3 and stage 4 of the severe dengue fever presents with shock, features of capillary leakage, hepatic, renal, cardiac, pulmonary, and CNS involvement, as already mentioned in the diagrammatic representation. So 80% of the infection, 80% of the patients having dengue infection, they will be asymptomatic. 20% will be symptomatic, but these 20% again can be divided into undifferentiated dengue fever, plain simple dengue fever, or the dengue hemorrhagic fever, where plasma leakage is the hallmark. This can be compensated, normotensive shock, or there can be a hypotensive shock. CNS involvement can be in the form of encephalitis, febrile convulsions, intracranial hemorrhage. GI involvement can be acute hepatitis, fulminant hepatic failure, cholecystitis, cholangitis, pancreatitis. Renal involvement can be in the form of acute renal failure. Cardiac involvement in the form of arrhythmias, cardiomyopathy, myocarditis, pericardial effusion. Respiratory involvement in the form of pulmonary edema, ARDS, pleural effusion. There can be conjunctival hemorrhage and visual impairment and optic neuritis also. Warning signs of severity and progression of dengue fever are recurrent vomiting, which is very important for us, dehydration, electrolyte imbalance, pleural effusion, ascites, GB edema, hemoptysis, hematemesis, hematuria, abdominal pain, gum bleeding, palpitation, breathlessness, hepatic dysfunction, hepatomegaly, oliguria, high hematocrit more than 45%, rapid thrombocytopenia, cold clammy extremities, rapid pulse, and hypotension. So we have to monitor the vitals in a very important manner. The differential diagnosis, we all know, it can be by malaria, enteric fever, tonsillitis, pharyngitis, influenza, leptospirosis, meningococcal meningitis, chikungunya, and Ebola hemorrhagic fever. This is important for us. Lab diagnosis. Hematological parameters, most important is the hematocrit and the platelet count. Virus isolation from clinical specimen in the first 6 days of illness. Viral nucleic acid detection test, that is dengue RNA viral genome, can be detected by the RT-PCR assay and the real-time RT-PCR assays also. We normally, what is available to us is the immunological response and the serological test, that is the heme agglutination assays, the complement fixation test. IgM can be also detected by the MAC ELISA and the indirect IgG ELISA assays. Viral antigen detection can be done by the ELISA test or the dot blot assay direct against the envelope or the membrane antigen, and the non-structural, that is the NS1, that can be detected in patients up to 6 days after the onset of illness. Commercially, tests are available for this, but detection between the serotypes is not possible. It provides an early diagnostic marker. The rapid diagnostic test, that is the commercially available test available to detect the anti-dengue IgG, IgM antibodies, are also available. Unfortunately, the accuracy of most of these tests is uncertain, and hence they have not yet been properly validated. So what we see is on day 1 and 2, there will be viremia. The NS1 will be positive from day 1 and 2. IgM will be positive from day 4 onwards. IgG will be also positive from day 4 onwards. What is the impact of dengue in pregnancy? The clinical manifestation, treatment, and outcome in pregnant women with dengue are same as the non-pregnant women. Diagnosis is delayed because of overlapping clinical and lab features with certain conditions during pregnancy, like health syndrome, pneumonia, PE, and hyperemesis. It is still uncertain whether dengue is a significant factor for adverse pregnancy outcomes like preterm birth or IUGR. Dengue fever does not warrant termination of pregnancy in mother who had dengue fever in the first trimester. Significant impact of dengue fever on parturition, as severe bleeding may complicate delivery or any surgical procedure performed in pregnant women with dengue fever during the critical phase. Risk of vertical transmission, risk of 1.6 to 64% in women with dengue fever during the perinatal period. Hence, newborns should be closely monitored. What is the management? Suspect dengue in pregnant patient coming with fever. Do a baseline CBC on day 1 and day 2 of fever. A hematocrit test in early febrile phase establishes the patient's own baseline hematocrit. In absence of patient's baseline, age-specific population hematocrit is used as the baseline. If the WBC count is normal or lower, suspect dengue fever. Repeat CBC after 24 hours and compare for the fall in platelet or rise in PCV. That is, a 10% rise is significant. There is no antiviral therapy available for dengue. There is no role of antibiotic, IV immunoglobulins, or steroids in dengue. All pregnant patients with suspected dengue fever are to be admitted in hospital for close monitoring. Monitor temperature, pulse, BP, pulse pressure 4 hourly. Ensure urine output at least 4 to 6 hours, that is 100 cc every 4 hours. Intake output record is to be maintained. Daily CBC and specific investigations are to be done. Paracetamol 500 to 650 milligram per orally 6 hourly should not exceed 4 grams in 24 hours. NSAIDs like ibuprofen and diclofenac are avoided. Withhold aspirin if the patient is already taking aspirin. Oral intake is encouraged. ORS, juice, coconut water, apart from routine food, is to be given. If nausea and vomiting, then IV fluids in the form of normal saline 100 cc per hour should be given. Watch for decreasing urine output, narrowing of pulse pressure, that is less than 20, delayed capillary refill more than 2 seconds. Watch for warning signs like vomiting, lethargy, abdominal pain, particularly when the fever is subsiding. Again, monitor pulse, BP, pulse pressure, and capillary refill hourly. Catheterize to know exact urine output, which should be 0.5 ml per kg per hour. Intense fluid, if there are warning signs, then intense fluid resuscitation with the help of normal saline bolus of 5 to 10 ml per kg per hour for 2 hours, followed by a maintenance of 3 to 5 ml per kg per hour according to urine output and pulse pressure. Avoid planned surgeries or induction of labor in this phase. This is the phase of dengue fever with warning signs. If there is inevitable delivery during critical phase, if the patient goes in labor, bleeding should be anticipated and closely monitoring. Blood and blood products should be cross-matched. Transfusion of platelet concentrate should be initiated if needed during or at delivery, but not too far ahead, as platelet is sustained only for a few hours. Here, the word mentioned is if needed. Trauma or injury should be kept to minimum. IM injection should be avoided. AMTSL is mandatory to avoid PPH. Misoprostol can be given. Check for complete removal of placenta. Fresh whole blood or packed cells should be administered as soon as significant bleeding occurs. Do not let more than 500 ml of blood loss to occur before replacement. If at all surgery is needed, anesthesia decided according to the platelet count. Regional anesthesia is to be avoided. Hemostasis should be proper during surgery. If the patient comes in shock, that is pulse pressure less than 20 millimeter of mercury, admission, oxygenation and ICU, investigation like CBC, renal function, liver function, and specific investigations have to be sent. Blood products to be cross-matched. Fluid bolus, that is 10 ml. The patient is already in shock. So now here it is 10 ml per kg over 15 minutes before the transfer to ICU. Second bolus of 10 ml per kg for the next 1 hour during transfer, and afterwards 1000 ml of IV fluid, colloid solution preferred. If hematocrit is decreasing, fresh blood, that is 10 ml per kg or packed cell 5 ml per kg has to be started. In the convalescence phase, there is a rise in WBC followed by a platelet count rise in systolic and diastolic blood pressure. Watch for fluid overload, that is cough, wheeze, and tachypnea. Patient has to be discharged only if she is afebrile for 24 hours without antipyretic. There is improvement in appetite. There is a normal HCT to baseline, rising trend of WBC and platelet, good urine output, minimum 2 to 3 days after recovery from shock, and there is no respiratory distress from pleural effusion or ascites. What are the do's in dengue during pregnancy? Suspect dengue in acute febrile illness, admission for close watch. Hematocrit is the sole lab parameter. Watch for signs and symptoms when fever subsides. Diagnosis of shock and treatment with intense fluid management. Keep blood products ready. Evaluate neonate for congenital dengue. Options of fluid resuscitation. Normal saline 0.9% should be used for initial resuscitation. Normal saline is preferred over ringer and DNS. Plain dextrose solution should not be used. Colloids should be used only after 2 fluid bolus in shock. Prophylactic platelet transfusion. Prophylactic platelet transfusion is not recommended unless delivery is inevitable and the platelet count is less than 50,000 per cubic millimeter for vaginal delivery and 75,000 for operative delivery. Clinically stable dengue with low or very low platelet count in critical and recovery phase, no platelet transfusion is indicated. What are the don'ts in dengue? No IM injection, no hypotonic IV fluids, no steroids, no antibiotics, no IV, only oral intake if tolerated. Breastfeeding is safe if mother is infected with dengue. Colostrum containing anti-dengue antibodies make babies immune from infection. Prevention, transmission of dengue virus can be done by combated by the mosquito vectors. Prevention of mosquito in and around houses and place of work, schools and health facilities. Personal protection from mosquito bites. Educating the community on risk of mosquito-borne disease, involving community participation in sustained vector control program. Emergency vector control measures such as applying insecticide as spraying during outbreaks may be used by the health authorities. First dengue virus vaccine, that is Dengvaxia, is developed by Sanofi Pasteur, is a live attenuated dengue vaccine. Its use is targeted for persons living in endemic areas between 9 to 45 years of age who have had at least one documented dengue virus infection previously. International Dengue Day observed on 15th June every year. National Dengue Day held in India on May 16th, so that various awareness programs can be conducted. Dengue notification, dengue in endemic areas in India. Cases of suspected dengue, probable dengue, and confirmed dengue should be notified as soon as possible so that appropriate health measures can be initiated. So the take-home message is timely intervention brings down fatality from 2% to 1%. Paracetamol only, avoid NSAIDs. NS preferred to ringer, no dextrose. Nursing care plays important role. Tocolytic agents to postpone delivery to a suitable time may be considered during critical phase of dengue, but there is lack of evidence for this. Transfusion trigger is low in dengue. Prophylactic platelet transfusion not recommended unless delivery is inevitable. Clinically stable with low platelet in critical and recovery phase, not in labor, no platelet transfusion. Platelet transfusion only given in presence of overt bleeding with low platelet count. Operative delivery for obstetric indication only. Delivery to be conducted in presence of skilled obstetrician and hematologist with blood products ready. Thank you. Here, I would like to bring to your notice two patients which I came across. One was a primary gravida. On the very third day of fever, febrile fever, I had already sent the investigation and she was a suspected case of dengue. She went into labor and she came in the hospital at around 10 a.m. She delivered around 12 a.m. I had sent the blood for cross match. And I had taken all the precautions, so there was no PPH. But 18 to 20 hours after delivery, she had a bout of bleeding. And this was again controlled, although the blood was ready, but that bout was controlled by various methods and the patient was stable. This patient, the baby had dengue, congenital dengue, and there was respiratory distress in the baby. In spite of being a 40 weeker rather, there was fetal distress in this respiratory distress in this fetus, and the platelets of the baby went down to 5,000. But the baby also survived even in spite of the fact that the platelets went down. There was another patient in the second trimester. She came to me with ascites, gallbladder edema, pleural effusion, and fever. But as soon as she was given fluids, all these ascites, pleural effusion, gallbladder edema subsided and she went home. The fetus is also fine. Now she's in the second trimester and there was no issues. So in spite of the fact that the dengue antigen test was negative, there was ascites, was pleural effusion, there was gallbladder edema, and the watch was kept for platelet count, which went down, but then it was okay. And in the first phase, in the first patient, the primary which went into labor, she went into labor at the count of 65,000. She went into in labor at the count of 65,000 platelet.
And she delivered vaginally?
She delivered vaginally. She came to me and 5 centimeter dilatation, and there was no immediate PPH, but she had a PPH after 18 hours. So basically here I have not mentioned, it is not just the platelet count. It is basically the platelet function that is also important, and we have to be careful for PPH, because in spite of the fact that she had a platelet count of 65,000, she went into a secondary PPH.
Very nicely managed, Ali. And thank you for a very comprehensive, informative talk as usual, which is need of the hour. अभी डेंगू इतना ज्यादा फैल रहा है कि सभी को सुनने की इच्छा थी. छोटे छोटे टिप्स जो मिलते हैं ना, वो बहुत काम के रहते हैं.
And initially, it is very important. You see the drop in the HB, TLC, TND count. There is definitely, we see that there is a drop, and then the platelet count drops.
Yeah, first the WBC count are low.
Yes.
Yes, yes. And वो बेबी का कैसे डायग्नोस किया कि डेंगू कंजेनिटल डेंगू है?
Actually, suspicion तो था, because the mother was dengue positive. Suspicion था, there was respiratory distress. So every day the platelet count was done for the baby.
अच्छा, okay.
As I was
platelet count के साथ में उसमें भी डेंगू टेस्ट.
हाँ, that came out to be
डेंगू
positive.
टेस्ट उसमें भी किया?
Yes, yes, that came out to be positive.
हाँ. और भी कुछ उसमें बाद में कुछ एब्नॉर्मलिटीज बच्चे में भी कुछ आया, ब्लीडिंग वगैरह?
The baby took almost 25 days to recover. The mother recovered in 3-4 days, but the baby took 25 days to recover.
Okay. Full term baby?
Full term. 39 weeks plus 4 days.
Any more questions? Unmute yourself.
The blood transfusion in that patient जो जिसका baby को भी congenital dengue था?
Actually, I had called, I gave her transfusion. It was not needed because there was just one episode of blood clot. And because I had called for the blood, so I gave her the Paxil. I gave her 2 Paxil. Otherwise, she didn't need blood transfusion. I didn't give her platelets also. Because the blood was already arranged. And the moment usko bleed hua, I called for the blood and transfused blood. What I think in retrospect, even if I would not have given her blood transfusion, she would have been okay.
I also managed a dengue case. She presented in the second trimester, and she was 26 weeks pregnant, came with mild fever, body ache, rhinorrhea, vomiting, and I admitted her with pain in abdomen also. She was not in labor. And I started IV fluids and paracetamol, and supportive treatment was given. Complete investigation was done. Her NS1 antigen was positive, but IgM and IgG antibodies were negative. And platelet count was 27,000, but she was asymptomatic. And so a physician told if it goes below 20,000, you can transfuse platelet. I repeated platelet count after 12 hours, and the platelet went down to 9,000. But still she didn't had any bleeding episode, but I shifted her to ICU. And there they transfused 8 platelet, and at last she had, I think, platelet count of 80,000 on discharge. Luckily, there was no bleeding except epistaxis, and that was also not much. And she went home well.
I had a patient in second trimester, again 24 weeker, but there was no bleeding, and the platelet drops to 30,000. But then after 30,000, it started rising. It didn't go further down.
9,000 पे आया और उसका BP काफी fall हो गया था, 80-40. That's why I shifted her to ICU. Luckily कुछ हुआ नहीं, कुछ भी. Baby was, मतलब वो FHS भी मुझे लग रहा था कि पता नहीं अंदर internal bleed हो, क्योंकि epistaxis हुआ था, पर कुछ
And I make a point that, you know, these patients where the platelet count is going down, I make a point that I check them in the ultrasound that कहीं कोई retroplacental bleed तो नहीं.
उसका check किया था, everything was normal. और भी किसी को कुछ questions हैं, please? Unmute करके.
like a dengue patient of 24 weeks pregnancy. So her platelets were 48,000. फिर थोड़े दिन बाद her platelets were 35,000. So मुझे इतनी anxiety हुई कि मुझे करना क्या है, like the patient is deteriorating और वो she is very stable. तो I called Dolly ma'am कि मैम अब करना क्या था. मैम ने बोला you have to do nothing, बस इसको admit रखो.
Just wait and watch.
कुछ नहीं करना है, बस उसका fluid management करना है. This is very important.
And that is also with normal saline. That is also with normal saline. Not Richter or DNS.
एक्चुअली जब वो 9,000 उसका प्लेटलेट आया मेरी भी पेशेंट का, तो मैं तो बहुत ही ऊंची नीची हो गई कि 9,000 तो बहुत ही कम है.
Yes.
But they say that if the patient is stable, even if at 5,000, it's okay.
हाँ, वो वैसे स्टेबल थी, पर पेन इन एब्डोमेन बोल रही थी, तो वो मेरे को अलार्मिंग लग रहा था कि कहीं अंदर उसको एब्डोमिनल सोनो नॉर्मल थी. हाँ, वही.
It was on the verge, right.
हाँ, और टॉक्सिक एकदम हो जाए तो अपन आईसीयू तो था नहीं, इसलिए उसको तुरंत आईसीयू में भेजा, बट वेल मैनेज्ड, फिर हो गई वो.
जाके थोड़ा देख लेना या किसी को बोल के पूछवा लेना.
एक्सक्यूज मी, और किसी को पूछना है कुछ? सो थैंक यू डॉली, शॉर्ट नोटिस पे तैयार हो गए.
ये रेडी था मेरे पास एक्चुअली, मेरे को कुछ बहुत एफर्ट करना नहीं था.
नहीं, और सुन के भी बहुत अच्छा लगा, इतना इंफॉर्मेटिव था, बहुत ही अच्छा लगा.
Yes,
सबको है ना, वेरी इंफॉर्मेटिव.
थैंक यू सो मच.
वो है कि मतलब नॉलेज मिल गया, एकदम से सोचा और आपने सारा दे दिया. सो इट वाज वेरी जल्दी हमको डेंगू का पता चल गया. इट इज वेरी नीडेड टुडे. थैंक यू सो मच.
But this is a good method, you know. अपन लोग you can prepare these subjects. It's just a brushing up, and you know this is a good method in the OPD also. You can just sit and hear.
हाँ, बिल्कुल, definitely.
Rather than making good arrangements and all that, it is a very easy method.
Yes,
and it just takes half an hour to 40